Episode 41, A Murmur Heard on a Pre-Participation Exam. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide some practice questions. This is a quote from the authors. The patient was a 20-year-old female, white, Division I collegiate basketball player. She was an international student in her final year of intercollegiate competition and planning to return home to play in the Europe Professional League. In the pre-participation physical examination, the university physician detected a grade 1 out of 6 systolic ejection murmur heard during auscultation and recommended the athlete be evaluated by the team cardiologist. The athlete's murmur had not been detected on previous pre-participation examinations by the same physician or when she competed in Europe. She had mild myopia but had never been diagnosed with any additional ocular problems. There was no reported history of respiratory difficulties, neurologic problems, or hernias. There was no family history of Marfan syndrome. There were no sudden deaths in her family. On examination, her arm span was greater than her height. She appeared to be of average weight for her height and had a normal body fat percentage for her age and sex. Her fingers were long and thin, and she had pectus carinatum, which causes a pigeon breast appearance in which the sternum comes to a point. She had a high arched palate and her feet were pronated. There was no evidence of scoliosis, thoracic lordosis, or kyphoscoliosis, but she did present with excessive ligamentous laxity. She had no stretch marks or muscular hypotonia. The EKG was essentially normal except for sinus bradycardia, which was consistent for her aerobic conditioning. My differential diagnosis, first on the list, is going to be cardiac abnormalities, including hypertrophic cardiomyopathy, potential connective tissue disease, and possible vascular abnormalities. I want to recognize the authors. This case was published in the Journal of Athletic Training in the year 2000 by Richard Lopez and Julie Berg-McGraw from Florida International University. I am Scott Hull, a primary care sports medicine physician, and I'm studying for my sports medicine certification exam in 2026. I hope you will join me on the journey. This podcast is for educational purposes only. On further evaluation, the echocardiogram demonstrated significant dilation at 5.8 centimeters of the ascending aorta, which was substantiated with subsequent CT of the chest. The constellation of these findings led to a diagnosis of Marfan syndrome. For comparison, a normal aortic diameter for a person of her height would be approximately 2.5 to 3 centimeters. This athlete had additional x-rays and laboratory testing which were otherwise normal. But based on the extent of dilation, the cardiologist recommended replacement of the aortic valve and ascending aorta with a composite graft tube and valve. In 2022, the ACC and AHA guideline for diagnosis and management of aortic disease recommends prophylactic aortic valve replacement when the diameter reaches 5 centimeters in Marfan's patients or 4.5 centimeters if there are additional risk factors such as a family history of aortic dissection, rapid growth exceeding half a centimeter per year, or progressive aortic regurgitation. This athlete was well past that threshold at 5.5 on echocardiogram and 5.8 centimeters on CT scanning. Based on the diagnosis of Marfan syndrome with a recommendation to discontinue basketball, the head athletic trainer worked with the athlete, coaching staff, and the players to carve out a new role for her within the team. As an experienced player and a college student with strong skills, she transitioned into coaching and managerial responsibilities. Okay, a couple of key takeaways on this case. Marfan syndrome is an inherited connective tissue disorder caused by mutations in the FBN1 gene on chromosome 15. That gene encodes for fibrillin-1, which is a glycoprotein that is a major building block of the extracellular matrix in both elastic and non-elastic tissues throughout the body. When fibrillin-1 is defective, connective tissue becomes less resilient to normal mechanical stress. Marfan syndrome is an autosomal dominant condition, but in roughly 25 to 33% of cases, neither parent is affected. The mutation can arise spontaneously or what the geneticist describes as de novo. That was the situation with our athlete. Cardinal features involve the cardiovascular, ocular, and musculoskeletal systems with substantial clinical variability both within and between families. Diagnosis is based on the revised Ghent criteria, and I will link those in the in the references. The Ghent criteria place primary weight on aortic root aneurysm and ectopia lentis as cardinal features. Among adolescents and adults with Marfan syndrome, aortic wall rupture with or without dissection is the most common cause of death. With timely diagnosis and multidisciplinary management, life expectancy now approaches that of the general population, which represents a dramatic improvement from the mean age of death at 32 years old reported in the early 1970s before modern surgical and medical interventions were available. I previously mentioned current AHA and ACC guidelines, which discuss competitive sports participation. In this guideline, athletes with Marfan syndrome should not participate in competitive sports involving intense physical exertion or potential for bodily collision. Even low-intensity sports participation is only considered reasonable if the athlete has no aortic root dilation, no moderate to severe mitral regurgitation, and no family history of dissection at a small aortic size. Okay, a couple of questions for you. Question 1. A 19-year-old male college volleyball player is found to have Marfan syndrome. Neither of his parents has been diagnosed with the condition. He asks how he could have inherited a genetic disorder if no one in his family is affected. Which of the following best explains this finding? A. Marfan syndrome is an autosomal recessive disorder and both parents are asymptomatic carriers. B. Marfan syndrome results from a de novo mutation in the FBN1 gene in approximately 25 to 33% of cases. C. Marfan syndrome is an X-linked recessive disorder and his mother is an obligate carrier. D. Marfan syndrome is caused by mitochondrial DNA mutation inherited exclusively from the mother. E. Marfan syndrome occurs only in individuals with a positive family history and the diagnosis should be reconsidered. Correct answer is B. Marfan syndrome is an autosomal dominant disorder characterized by pathologic variants of the FBN1 gene on chromosome 15, which encodes for fibrillin 1. While it is typically inherited from an infected parent, approximately 25 to 33% of cases arise spontaneously from mutations, which are called de novo mutations, meaning neither parent carries the variant. This is an important concept in our screening of individuals during pre-participation examination, noting that an absence of family history does not completely exclude the diagnosis. Question 2. A 22-year-old male with Marfan syndrome has an aortic root diameter of 4.2 centimeters, which represents a Z-score of 2.8 on echocardiography. He is hemodynamically stable with no aortic regurgitation. His cardiologist initiates medical therapy to slow the rate of aortic dilation. According to the 2022 ACC-AHA guidelines, which of the following is the recommended first-line pharmacologic approach? A. Calcium channel blocker at maximum tolerated dose. B. ACE inhibitor combined with a diuretic. C. Beta blocker or angiotensin receptor blocker at maximally tolerated doses. D. Statin therapy to reduce the aortic wall inflammation. E. Aspirin and clopidogrel for antiplatelet prophylaxis. The correct answer is C. The 2022 ACC-AHA guideline for diagnosis and management of aortic disease recommends treatment with either a beta blocker or an angiotensin receptor blocker at maximally tolerated dose, which is a class 1 recommendation to reduce the rate of aortic dilation in patients with Marfan syndrome. Combination therapy with both agents is reasonable for progressive dilation. Question 3. A 21-year-old male college basketball player is diagnosed with Marfan syndrome. His aortic root Z-score is 2.5 and a measurement of 42 millimeters. He has no mitral regurgitation. His left ventricular ejection fraction is 60%, and there is no family history of aortic dissection. He would like to continue playing competitive basketball. According to the AHA, ACC scientific statement on competitive athletes with cardiovascular abnormalities, which of the following is the most appropriate recommendation from the team physician? A. He may continue playing competitive basketball without restrictions since his aortic root is less than 45 millimeters. B. He may participate in low and moderate static, low dynamic competitive sports only. C. He may return to competitive basketball after prophylactic aortic root replacement. D. He may participate in competitive basketball if he takes a beta blocker consistently. E, he should not participate in any competitive sports involving intense physical exertion or the potential for bodily collision. The correct answer is E. The AHA-ACC scientific statement states that athletes with Marfan syndrome should not participate in any competitive sports that involve intense physical exertion or the potential for bodily collision. This represents a Class 3 recommendation. Because basketball is classified as a high dynamic, moderate static sport with significant potential for bodily collision, even though this patient's aortic root is only mildly dilated, the diagnosis of Marfan syndrome restricts participation in this high-intensity competitive sport. Participation in low-intensity competitive sports may be considered only if the athlete has no aortic root dilation, which is a z-score of less than 2 or less than 40 millimeters, no significant valvular disease, and no family history of dissection at small aortic size. This particular patient's z-score of 2.5 exceeds that threshold, further supporting disqualification. Beta blocker use before games or consistently does not change the eligibility recommendation. Thank you.